Okay. The function of potassium is critical for many, many cells. Okay. Electrically, it's really the major determinant of resting membrane potential. It's necessary for its transmission of nerve impulses in the sense that it helps repolarize the cell. It's not what actually propagates electrical activity. That's the sodium channel opening, but it's actually the repolarization that's responsible for is by the potassium channels. Okay? It's essential for normal cardiac rhythm function. Motor-wise, it's also essential for skeletal and smooth muscle contraction. Again, it's not really responsible for the contractile component of it or the initiating component, but it's very important to repolarize the cell so you can get the muscle to contract once again. Okay? For metabolic, it's very important for regulation of intracellular electrical neutrality in relationship to sodium and hydrogen. It's required by glycogen deposition in the liver and skeletal muscle, and is very important for intracellular fluid osmolality levels. Renally wise, the kidney doesn't really have as tight a control as sodium because almost everything that we eat has what in high concentrations? Potassium, because it's found in every cell. It's found in every plant cell that you eat. It's found in every kind of animal that you eat. Okay, so potassium is pretty much very evident in any nutrition that you get. Okay, so the body doesn't do as good a job as it does with sodium, which is essential. Okay? Sodium is so essential that any major city in the ancient times was actually established next to a what? A salt deposit. Okay, any major city in the world, pretty much before industrialization, really has a salt lick or a salt deposit very nearby. Okay? So without it, you can't really sustain civilization, especially pre-industrial civilization, because you use sodium for what? Preservation, meat preservation. So without salt, you can't preserve your meat and stuff. Anyways, potassium is regulated via the kidneys, but really the kidneys have a very hard time conserving potassium, and this will be discussed to a lot more, example in the kidney section. The other one that's the other hormone that is partly responsible for regulating potassium is aldosterone, which also regulates sodium balance. So just make sure that you know that those are both connected together. Local cell control is where it's at when we talk about how reverse hyperkalemia. Okay, let's say a patient is given a certain drug. Okay, the most common drug that kills patients under anesthesia by accident is if you give somebody succinylcholine who has some form of demyelinating disease. Okay? That means spinal cord injury or demyelinating disease, a patient who's had a stroke, or a patient who's had electrical burns, or any kind of burns that eventually causes the electrical system to be shut down to the muscle, will induce a situation where the muscle becomes covered in acetylcholine receptors. When you give that person succinylcholine, you'll get a massive depolarization, which then causes a massive repolarization to take place, which causes a hyperkalemic arrest, and the patient will die. Okay? They will go asystolic on you. Okay? Well, basically the potassium levels that begins to increase is you'll see the T waves begin to peak. Then eventually you see the PR interval begins, and as well as the ST segment begins to widen, as well as the QRS. You get into what's called a sinusoidal pattern, and then you get into an agonal or asystolic pattern. So that's really not good. You want to be able to reverse this. Now the trick is don't panic. It's not the end of the world. And that's the first thing you got to do is take a big deep breath and say, I got to do everything that I remember Dr. Nolan lectured about so the patient can do fine. So don't freak out. You start doing your CPR. Okay? If you're in the process of intubating somebody for a rapid sequence, then intubate them. Okay? You got to get the tube in because that's the reason that you gave the drug in the first place. And if you don't, the person may aspirate and die from secondary complications of that. So get the person intubated quickly. And then the first thing that you give is calcium. The reason you're giving calcium is because it's a membrane stabilizer. Okay? What it basically is going to help do is going to help establish the gradient and stabilize it so it doesn't get any worse. Okay? The next thing you want to do is you want to drive the potassium back into the cells. because potassium inside the cells makes the cells happy. Okay? What kills the gradient is having the potassium outside the cells. So what drives potassium back into the cells? What's that? Insulin? Yep. Insulin would be my secondary choice. My first choice is hyperventilation. Immediately hyperventilate and continue doing CPR, because what that basically is going to do is going to remove CO2, which is going to make the acid in the body to drop, okay? So that person is going to become hypocarbic, which ends up causing an increase in pH, okay? So the second thing you want to do is, besides hyperventilating, is immediately give bicarb. Bicarb is also going to make the person alkalotic, and alkalosis drives potassium back into the cell, okay? It also pulls hydrogen ions from intracellularly outwards, which is what's called an antiport system. Hydrogen ions come out for every potassium that comes in, okay? So that antiport system can be activated by both those systems. In addition to that, you can add another, which is in this case a symport system, which is you give insulin and glucose. Insulin causes the pump to get activated, and glucose helps pull the potassium in with it. Okay, so the symport system is basically for every one sugar, it drives in potassium with it. Okay, so that's your second mechanism. And the other thing that can also help drive potassium into the cell is beta-2 stimulants. Okay, beta-2 stimulants. Okay? And you think to yourself, man, why beta-2? Why not beta-1? What's a beta-2 stimulant? What's it? It's bronchodilator. What's in this? Let's say if you're running, what is the essential hormone that's being produced when you start running? Epinephrine. Epinephrine has a high amount of beta-2 activation. Okay, it's going to cause bronchodilation. It's going to cause an increase in beta-1, which increases heart rate and contractility. But the beta-2 effects on the skeletal muscle is it drives potassium back into the cell rapidly. So in other words, epinephrine is an enhancer of skeletal muscle function because it's helping repolarize you more efficiently. So epinephrine may actually be a good choice. Okay? The downside to it is that it can cause acidosis, which may not be the good benefit of it. Okay? So it has to be balanced. What may work better for you is to give a bronchodilator. Okay? Just spray a bronchodilator that's a beta-2 agent selectively, and you'll get more potassium being driven inside. Now, you may not think that's important, okay, because you think, what's the chance of that being significant? So I'll tell you a story. I was giving this lecture a few years ago, and I went from here to work in OB, and I was talking to one of the mothers that was having a baby, and she was very worried, not about her delivery, but she was worried about her son at home. And I said, so what's wrong with your son? And I said, well, he's having severe cramping pain at night where his legs literally cramp up and he screams all night. So I said, well, what's his medical problem? He says, well, he's got asthma. Okay, so he's got asthma. Okay, what does he do at night? He does an inhaler right before he goes to sleep. So I just told her, I said, well, it's a really simple solution. And she goes, what's that? She says, just have your kid eat a banana before he goes to sleep. Right before, or have potatoes right before you give him the bronchodilator. And the problem will go away. About 2 months later, actually about 6 months later, I'm walking with my wife in the supermarket. All of a sudden this woman comes over, gives me a big hug, and says, oh, you saved my son's life. I'm going, whoa. It's like, so I didn't realize who she was. And then she said, oh, so how's he doing? She says, as soon as I started doing that, it went away. So simple, something that nobody thought of. Okay, but that's how powerful this stuff is. In some people, it actually has a tremendous effect. And if you're in a bad situation like you are in a code like that, a bronchodilator is very much benign, and you can have significant effect of pulling sodium back in, bringing potassium back into the cell. Okay? And then we'll stop here in a minute. Hypokalemia is, on the other hand, is reverse of hyperkalemia. It's a low level of potassium. Usually it's less than 3.5 milliequivalents per liter. Now, people will freak out, and you'll get in clinical, and they'll say, oh, well, I can't give I can't do an anesthetic with a potassium of 3.5 or less. No, no, no. You can give an anesthetic at a potassium of 3 and still considered safe. Okay? But you just got to be careful because that person is more likely to get into an arrhythmia. Okay? Why? Because as soon as I put the person to sleep, what am I going to do? I'm going to immediately intubate the patient and begin to hyperventilate them to a certain degree. Almost everybody that's under general anesthesia has a CO2 of what on the end tidal CO2? 30. Okay? And you ask yourself, why? Why do we drive it down to 30? Well, because I don't want the guy to breathe. Okay? I don't want him bucking or moving on the tube. So almost everybody hyperventilates them down to around 30. Okay? So what happens to my potassium when I do that? I dump it even more. So then I can get into arrhythmias. Okay? And that's what I observed about 3 weeks ago. I had one of the new juniors coming in, and they got really excited. They were ventilating, and then all of a sudden we started seeing a lot of arrhythmias, and I said, you know what, why don't you stop ventilating? And he goes, no, I don't want to do that. It's like not going to get any oxygen. It's just trust me, just stop ventilating for a second. You're hyperventilating the person way too much. Now the potassium must be like 2.5. And as soon as he stopped ventilating, the CO2 started coming back up, potassium starts coming back out, normalizes, and the arrhythmia went away. Okay? So this stuff is all connected, believe it or not, how we discuss this with you. Okay? So the things that can occur is when you're low on potassium, be careful about hyperventilation. You can really get yourself into worse trouble. As do you treat this beforehand? It depends. If you have time, then I would recommend you do that on the floor. The other thing that I'd recommend before you start treating hypokalemia is that you must check magnesium levels. It is worthless to start giving a bunch of potassium to somebody unless you check magnesium. How many people here have treated potassium and never checked the magnesium level? Come on, don't lie. Put your hand up. Okay. All right. Almost all of you did. Okay. I did too. Okay. And the reason that's a problem is because we end up giving many, many equivalents of potassium, and then when you check your potassium the next day, you see no effect. And you're wondering, why is it not going up? Okay? The reason it's not going up is because the magnesium levels are critically low. And the magnesium, remember what the magnesium levels were in the cell before? It's 20 milliosmoles per liter. If that's really low, then the potassium won't go into the cell. Okay? So it's one of those things that are essential. Hypokalemia, it can be from reduced intake of potassium. It's just not usually the event. It's usually from increased potassium loss through the kidneys. It also can be bound up by antibiotics of certain kinds. And you can also lose it from potassium losses from diarrhea and as well as vomiting. Manifestations is that because it's so critical in almost all the muscles for repolarization as well as electrical cells, it causes electrical disturbances, which causes conduction defects. It also causes motor weakness, metabolic problems, as well as renal problems. This is an example of what happens when you induce somebody into a hyperkalemic state. Okay? If in hyperkalemia, okay, you get decreased excitability. Okay? So you're up here. Just use the one that I just showed you before. I think it's much better than the way the book explains it. I think it's very confusing. Okay? Versus if you're hypokalemic, you tend to drive this way down again. And what happens is, if you look at it from the standpoint, this is the normal. Okay? And then you're coming back. The slope is coming back up to this point. If you take a look at this slope, same slope, it reaches actually the point faster. Okay? And because it reaches a point faster, you get a more rapid heart rate. Okay? So that's the basic theory behind hypokalemia induces tachydysrhythmias, and hyperkalemia induces a state where you're above the threshold, so the cells essentially stays depolarized and causes a very bad effect. Okay? So this is what I was trying to show you here. Actually, I got it in the slides now, so I must have moved it in. Okay? Make sure to review this portion of it. This is the pacemaker cells here, and this is the cardiac myocyte cells. But both the effects are bad in the sense of hyperkalemia, as it causes a depolarized arrest in both situations. Now, why is that important? When do we use this? Is potassium a bad thing in the sense that do we use it clinically in any way? We do it in open hearts. Okay? In the cardioplegia solutions, we basically give hyperkalemic arrest. We give very high doses of potassium to stop the heart fully and basically inhibit the electrical activity as well as the muscular activity of the cell. Okay? So doing that properly is very important. Okay? So it's a great way to learn what hyperkalemic arrest looks like. You can see the pattern, which is the T wave elevation followed by the QRS widening with eventually this sinusoidal pattern and eventually loss of your rhythm completely. This is what it's trying to show you here. This is somebody who's normal kalemic. This is a hyperkalemic patient initially where you get ST segment depression. But the most important thing is a prominent increase in T wave in hyperkalemia, which is right here. This is what I'm trying to think of. This is the peak T wave. Okay? Eventually you get widened QRS, and eventually you get asystole from it. Hypokalemia, on the other hand, you get a small T wave, okay, and you get the ST segment depression in that situation. Okay? And we'll stop there for 10 minutes, and we'll start back up.